Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you for joining us at Breakfast at UMHealth this morning. This is the 38th series of Breakfast at UMHealth. Myself, I'm Professor Dr. Muhammad Yazid Jalaludin, a Senior Consultant Pediatric Endocrinologist from Department of Pediatric, Faculty of Medicine, University of Malaya. I'm delighted to introduce you our new addition to our Pediatric Endocrinology group, Dr. Annie Leong. So she had her training in Ministry of Health, University of Malaya, as well as in Singapore. Today, she will be talking to us on diabetes technology, a new era for children with diabetes. Over to you, Dr. Annie.
All right. So good morning, everyone. Thank you for allowing me to talk about this topic today, which is diabetes technology, a new era for children with diabetes. We would like to take this opportunity to create some awareness regarding what is available in terms of technology advancement for the children worldwide in our country as well as in our center. So first, we would like to ask the most basic question: what is diabetes? I'm sure all of you know this is a chronic metabolic condition causing the blood sugar to be high. And why people are always scared of the diagnosis of diabetes? Because it means that they need to check the blood sugar regularly. It means there is multiple finger pricking. And most people are fear of insulin injection. So next question, can children develop diabetes? You'll be surprised even among many of the healthcare personnel, they have doubt about this answer. And the answer is yes. And in fact, most children with diabetes are insulin-dependent type 1 diabetes patient. They require a regular insulin injection every day and for lifelong. As follow to this International Diabetes Federation, it's estimated that almost 1,000 of type 1 diabetes cases in the children aged 0 to 19 in our country up to the year 2019. And more than 70% of them are type 1 diabetes. So how many types of diabetes are there in children? The most common, as I mentioned earlier, is a type 1 diabetes patient. More than 70% of them in Malaysia of those with diabetes children. And the cause is due to autoimmune problem, whereby the immune system are getting confused and they attack their own pancreas. So the pancreas are unable to produce any insulin, and hence the patient are dependent on the insulin for lifelong. Type 2 diabetes is also almost like an adult type 2 diabetes. It is rarer in children, almost about 70% of them for the diabetes children in Malaysia in 2019. However, these incidents are increasing with the rate of increasing in terms of obesity in children. The cause is also similar to adult. It is due to insulin resistance. However, the type 2 diabetes are more aggressive in children. So despite the diet and lifestyle modification, many of them a lot of times still require more medication, and many will also need to get the adjunct of insulin injection. Other rarer type of the insulin of diabetes, including neonatal diabetes. This can occur to the infants as young as few days old infants. And another one is a MODY or monogenic diabetes. It can occur in some of the older children in the adolescence. So these are rare. They are usually due to genetic mutation, and some of them are insulin dependent as well. So what is the difficulties faced by all the type 1 diabetes patients in their daily life? Here we would like to illustrate here a typical type 1 diabetes patient's daily routine to illustrate how tough is their life because they are insulin dependent. So every day when everyone wake up in the early morning rushing to school, they have to do a few more steps before they can rush to school. Soon after wake up, they have to check the blood sugar. They have to calculate how much food they're going to eat, calculate how much insulin they need to be injected. Then they have to inject the insulin first before they can eat. Then only they can rush to school. Hence, they are usually quite rushing when they go to school. Similarly, when in the school recess, instead of like friends who just rush to the canteen, again, they have to go through the step of checking the blood sugar, calculate how much they're going to eat, how much they're going to inject first, then only they can eat. So this routine is repeating for lunch or tea time for dinner, even before bed, even they decided not to have supper, they still had to go through the routine of checking blood sugar. They had to give daily basal insulin before they sleep. And most of them, once in a while, we will advise them to wake up middle of the night to check the blood sugar about 2 to 3 a.m. to make sure they have no blood sugar at night. So how many insulin shots and blood sugar check they need per day? So you can see they need at least sugar check of 4 to 6 times per day and insulin injection of 4 to 6 times per day, which come out to almost 1,500 to 2,000 times per day. So this is definitely a very difficult situation for them. And it's followed the guideline ISPAD 2022, which is an International Society of Pediatric and Adolescent Diabetes guideline. To get the optimum diabetes control, they need to check the blood sugar at least 6 times per day in all the type 1 diabetes. Hence, it is not easy for them to get the optimum diabetes control. How did our patient do with the control in Malaysia? This is one of our old registry in 2006 to 2008, whereby it reported that the average HbA1c of the patients of Taiwan are 10.8%. Unfortunately, we do not have the latest registry, but based on some of the published reports, example, one of these is one of the center in Kelantan, and the average of a randomized study for 35 patients, mean HbA1c is 10 to 11%. And another one is a center in KL, about 40 patients with mean HbA1c of 9.4%. This is one of the unpublished data that our master recently, out of 70 adolescents, it was noted that HbA1c is 8.3%. So you would think our patients are doing better. However, the recommended guideline for the target HbA1c for children should be less than 7%, follow the ISPAD guideline. And why are we so particular about the HbA1c? Because this is based on one of the famous DCCT trial in 1993, which have followed up almost 1,500 of the children over 11 years. And it has clearly shown that the higher the HbA1c, the higher the risk of them getting the diabetic complications. This including retinopathy, nephropathy, neuropathy, or microalbuminuria, which is early signs of nephropathy. So if the patient have a HbA1c of 10%, then they are getting almost 7 times of the relative risk of developing the retinopathy as compared to the normal population. Even if their HbA1c is 8%, it is still about 3 times of the normal population. So if it's possible, we want them to have a lower HbA1c, provided that do not cause a hypoglycemia. So for children, we aim at least 7% and below. But if adults or even older children, you want it to be even lower, by about 6.5%, almost same as a normal population. So it is definitely not easy to achieve that kind of optimum control, and that's where we need the technology. If from this chart, we can see how does the technology evolvement help to reduce the diabetic complications. Example, heart complication, kidney, eyes, nerve, and the joint complications. We can see with the advancement of the technology, the risk of complication has drastically reduced. And from here, the main focus of the technology are actually based on convenience of checking blood sugar and convenience of giving insulin. Even up before 50 years ago, there is no such thing as a glucometer. So slowly, there is a possibility of doing a point of care testing by the glucometer at the bedside, and patients are able to give the multiple dose of insulin at home. And this slowly have improved and evolved. And nowadays, if the patient can afford, right, we would strongly recommend for them to use a continuous glucose monitor, whereby they can directly see the blood sugar without finger pricking. Previously, it was a blinded CGM where the patient can't see the readings. They have to come to the hospital and be logged into the system. Only we can see what happened for the past 2 weeks. So nowadays, with the advancement of the smartphone, etc., patients can directly see their glucose monitors in the past 24 hours in the real time. And in terms of the blood sugar insulin delivery, nowadays there are more and more advanced delivery system, that they can be given continuously through the subcutaneous infusion sets. This is called an insulin pump. And the involvement of this is actually nowadays with the CGM and the pump together, they can start to communicate with each other. Example, the sensor augmented pump, whenever the CGM has detected the low sugar, they can actually tell the pump to stop giving insulin. So it is safer for the patient. And the latest version of the pump that is available worldwide as well as in Malaysia is this hybrid closed loop pump. It is even better, almost like an artificial pancreas, whereby the CGM can directly talk to the pump. So whenever the sugar is high, they will tell the pump to deliver more insulin. Whenever sugar is lower, they will tell them to reduce the insulin infusion. So this is almost same as the artificial pancreas, except that they will still have to key in how much food they're going to eat. This is another diagram to show the changes in the technology. So more than 100 years ago, that is where the insulin was discovered. Before that, the diabetes means it's a fatal disease. And in 1950, they start to have the disposable glass syringe. And this is a first generation pump. This is huge that they had to carry around. But that is the starting point of the smaller pump from there. And the glucometer is only available since 1970s. And the first insulin pen, that's what our patients are using now. This is the pre-filled pen that they can easily just open and inject and throw away. So this is different from the previously, they had to withdraw the insulin and dilute them. So that is very difficult, very troublesome and can be dangerous mistake as well. So this is the advancement for the CGM to the currently the intermittent scan CGM. And now the CGM can communicate with the pump. As I mentioned, this is a sensor augmented pump, whereby the sugar low and it will suspend the insulin infusion. And this is a hybrid closed loop pump. And this is the first bionic islet pancreas. This is the latest, almost like an artificial pancreas, unfortunately not available in Malaysia. In this pump, even when the patient eats, they do not need to put in how much they eat. So the pump is supposed to be able to detect how much food they eat and will give the insulin delivery accordingly. So this is even better than the current pump available. So anyway, we have seen that there is a good advancement in terms of the technology for the patient. So how many types of CGM that is available here in Malaysia? This is an intermittent CGM, or we call a flash CGM. Basically, patients have a sensor on the body and they need a reader that's go near to the sensor to get the reading each time. So they have to scan each time to get the glucose reading. And this is called a real-time CGM, whereby they do not need to scan. The CGM can directly communicate with a reader, and usually it means a phone. So they just need to Bluetooth the reading. So basically, without them scanning, the patient can get the 24 hours glucose readings. And in fact, with the cloud system, even the parents can access to the system. The patient are far away, they say at home or in the school. And the healthcare personnel can also access to the readings. The only downside of it is most of the device need a phone. So for our school-going children, it can be quite difficult because most of the school do not allow phone. And even when we give the letter, some of the school do not allow that, and it can cause some stigma to the patients. So how does the CGM work? This is illustrate that the traditional blood glucose monitor with directly checking the sugar in the blood vessels. The sugar are illustrated from all these blue dots, right? For the CGM, it's actually a sensor just below the skin. It's detecting the fluid underneath the skin. So that is detecting the blood sugar of the fluids. So of course, there is some delay for the blood sugar to travel from the blood vessels to the interstitial fluids. And hence, there is sometimes some delay of the sugar changes is detected by CGM as compared to glucometer. However, with the advancement of the CGM nowadays, the results are getting more and more accurate and nearer to the glucometer readings. And with the traditional glucometer, we just get the pinpoints of the blood sugar readings, example, at a certain hours. So from here, these 4 dots, it will look as if it is within the range that we want. But if you wear the CGM, you can see there is a lot of high reading and low reading that is not detectable by just 4 points sugar monitoring. And beside that, there is a lot of other information that is available from CGM, which can be found from glucometer. Example, this is the concept of time in range, which we prefer to look at the sugar control as compared to the every 3 months HbA1c. Because this we can see even over 24 hours, how does the patient's sugar control. Example, we want their target range to be from 4 to 10 for most children, and we want the target to be more than 70% in order to get a good HbA1c. And the low sugar reading should be less than 5%, and the high reading should be less than 25%. Beside that, the CGM can also, the app can calculate the estimation of HbA1c based on this GMI. They can tell roughly how many percent of the HbA1c just over a day, and they can show the glucose variability, which shows how much fluctuation of the sugar from high to low. So the lower is better. And from here, just over this graph, we can see what is the sugar trend for the past, for the 24 hours, for how many days in the they're using CGM. Example, they're using CGM for 2 weeks. We can see for the 2 weeks from what time to what time, the patient usually have high sugar and when they usually have low sugar. So this kind of graphic illustration is much better to help patients understand about their sugar trend and hopefully improve their blood sugar control. So because of the advancement on the CGM technology, the guideline has also changed. Previously followed the UK NICE guideline in 2015. It was only CGM only recommended for a limited patients to ensure that course is effective. However, 3 years later, with the advancement of the CGM technology and it has become more affordable, CGM is recommended to be offered to all the children and the adolescents living with type 1 diabetes. However, due to the high cost, it is not very widely acceptable or used in our country. In a lot of the country like UK, they are being subsidized by the government or even insurance company. So what about those patients who cannot afford to use CGM? So we always encourage them to use other technology. Example, many glucometer can be paired with an app to help them to manage the sugar. Example, one of these meter is actually freely available to our patients, and it can be paired to a phone with an app. So basically, whatever the reading is in the glucometer, it can be directly linked to the phone, and it makes the documentation of the sugar much easier. And they also can document what they eat, take a photo of the food, etc. And there are some functions in those apps. They can calculate, estimate the HbA1c. They can also help to calculate the insulin injection that they are needed based on the blood sugar as well as the food they're going to eat. So after knowing about all this advancement in the technology, how did our center progressing in diabetes technology usage for the past 20 years? So I just had a quick glance to our records recently. It shows only about 20% of our patients are using CGM intermittently, and only about 30% of them are actively using those glucose management apps, even though they are freely available. And only about 8% of our patients are using insulin pump. Just want to show you here, even the Barbie have launched the first ever doll with type 1 diabetes. So you can see the Barbie doll is wearing a CGM and a pump. So basically, this type 1 diabetes is actually quite not uncommon in a lot of Western countries, and many of them are being subsidized. So it is easier to accept that patients needed the regular insulin pump and the CGM. So I just want to show this is one of the grants that we managed to secure, and we would like to thank University Malaya for giving us this PKP grant. So basically, we are checking the impact of intermittent use of CGM for our adolescent patients. They are mainly either type 1 or type 2 diabetes patients with the insulin more than 1 year, age 10 to 18, and they are poorly controlled with the HbA1c more than 8%, and they have either not been exposed to CGM before or not been used for more than 6 months. So in this study, we give them about 2 CGM for 3 months, and we are not just giving them for free, but we want them to really learn about the usage of CGM. So you can see this is actually quite a tedious study. First, we will give them the education, and then we will follow them up through a telemed to make sure they are using the CGM well. So in day 7, so each CGM usually lasts for about 14 days. So we will meet them on the Zoom in day 7 and day 14 to make sure they understand what is the trend of the CGM and how they can do to improve it. And after that, they will continue with the usual blood sugar checking, and they will apply the second CGM on their own for the next 2 weeks. And again, we will follow them up in day 7 and day 14. And again, they will get check the sugar on their own after 4 weeks. So we will see them in the clinic after 3 months and 6 months, checking their sugar control in terms of HbA1c and a short questionnaire. I just want to illustrate that we can actually see every single patient's real-time CGM following the cloud system, as long as the patient allows us to do so. So we can see this patient, the sugar is mostly within the range, and some of them has a lot of deranged sugar, some have a lot of hypo. So based on this, we can actually communicate with the patients and try to make them understand why their sugar trend is as such and what they can do to improve the sugar trend. In fact, this information is also available to their caretakers, the parents, so that can be also helping them to remind them and help them to manage the sugar better. So this is just a preliminary result from the study. So the study, we have just managed to recruit about 2/3 of the patients, and only about 1/3 of them have completed up to 3 months of the study. And here we compare their HbA1c at baseline and 3rd months of the study. So we can see that most of the patients have shown improvement. And out of the 9 patients, the mean HbA1c at starting is about near 10%. And after 3 months, most of them had dropped in the mean of about 9%. So the changes is significant, less than 0.05. You may think that this is 9% is actually not good enough. However, for our patients, sometimes we're running with the HbA1c of 12, 13. This is actually showing a good and remarkable changes. So after talking about the CGMs, here I would like to share some information about insulin pump that is available in Malaysia. So this is a traditional insulin pump. Here, this device is where we keep the insulin, and there is a tubing and an infusion site where the insulin will be delivered. So these sites, they will change every 3 days. So whenever the patient want to eat, they just have to key in how much carbohydrate they eat and how much blood sugar that they check, and the pump will calculate for them how much insulin to be given, and the patients just have to press a button and insulin will be delivered. So it means the patient do not require multiple insulin injection every day. They just need to change this needle site every 3 days. In Malaysia, this traditional pump costs about 10,000 for the pump with the warranty of 5 years, and monthly consumable with all this tubing costs almost about 500 a month. This is a newer pump. This is a tubeless insulin patch. As you can see, this pump do not have the tubing, different from this patient. So it can be a bit more convenient for the patient who dislike all the tangling tubes. Okay. However, this technology is still quite new. The one that we have is actually originated from China. So you can see the device, even though it is tubeless, it is still quite bulky. Okay, so it is still rather new. We are still waiting for more feedback from the patients. But this pump is relatively cheaper. They offer free pump, but the monthly consumable is about 500 per month. And this pump is what is the most advanced that we have, and the latest version is, as I mentioned earlier, hybrid closed loop pump is using an automated insulin delivery system. So for this pump to work, they will need to wear the CGM continuously, and the CGM will directly communicate with the pump. So whenever sugar is high, they will actually let the pump give more insulin delivery, and if the sugar is low, they can suspend the insulin. And these changes occur every 5 minutes. So this makes the blood sugar control much easier and much better, right? The only thing is patients still have to key in how much food they're going to give. Okay, so this pump It's currently the most advanced that we have, and it costs 30,000 for the pump with a warranty of 5 years. And a monthly consumable is higher, almost 1,800, because they also have to purchase the CGM. What about other devices that is we hope to come to Malaysia but not yet here? Is a smart insulin pen. So some patients do not like the insulin pump attached to them for 24 hours. So this is an alternative that can be considered. Basically, this pen can talk to the CGM. So whenever the sugar is high, they will actually instruct, can actually calculate how much insulin is needed to be given, and there are even an alarm system through the Bluetooth. So they can actually alarm the patient to give the insulin, and they can calculate how much insulin to be given. Right, so it is actually safer and used as a good reminder for the patient. And similarly, the information can be accessed by the parents as well as the healthcare personnel. And this is an Omnipod, is another tubeless insulin pump. This is available in overseas but not in Malaysia. This is a more established system. Apparently the feedback is good, but if you can see, the device is still quite bulky. So I'm not too sure how our patient will able to accept this pump. But they are not yet in Malaysia. We hope they will come one of the day. So here I just want to illustrate a few of the patients, how are they doing with multiple types of the pump. So when they are very traditional insulin pump without CGM, we find the control can still be deranged, especially if they do not check the blood sugar regularly. Example, one of this patient, despite wearing insulin pump, the sugar reading are mostly between 10 to 20 plus. Okay, that is because if you see the patient is highly checked the blood sugar, just probably about average of 1 times per day, and hence the blood sugar cannot be really well controlled. It's average about 15 here. And if I look through some of our patients, about 4 patients, their average HbA1c is range from 8 to 10.5%. So it depends on the discipline of the patient, or how often they check the sugar, how often they key in the readings. What if the patient using the pump but the CGM separately? So this definitely will make the control much better. Example, this is one of the patient. We can see the target in range is much better. You can reach almost near to the target of 70%. Of here is about 68%, and the estimated HbA1c is about 7.1%. However, because the CGM is still require the patient to put in the data to the pump, right? So sometimes they are forgetful or they are very busy, so then they will not optimize the usage of the pump and the CGM. Our patient, in average, about 6 of them, their HbA1c range from 7 to 9%. So again, it still depends on the discipline of the patient. So what about the patient who are using the most advanced pump? So definitely the technology is doing a good job. They can actually achieve much better target in range because the pump are doing most of the work with the CGM synchronizing. So in this patient, you can get almost more than 70% or 80% of the target in range, and the HbA1c can achieve less than 7%. So we have almost about 5% of the 5 patients using the pump in our center, and I just trace back the HbA1c range from 6 to 7.5%. In fact, the patient 7.5%, I think the setting can still be optimized. So in short, in summary, diabetic technology has evolved significantly for the past 2 decades, and this has significantly improved the diabetic care and quality of life of our patients. It is important for us to create awareness to the healthcare personnel, the parents, as well as the children with diabetes, so they are aware about those available gadgets, and hopefully they are keen to try on it. However, because all these devices are very expensive, okay, so we need more voices to reach to our authorities, our government, the insurance company, as well as NGO, hoping that they can help to subsidize some of the patients with children. When I was doing my fellowship in Singapore, I remember there's one NGO who subsidized all the type 1 diabetes with CGM. And in 2022, the government have just approved a subsidy for insulin pump, but that's for the basic pump. So I hope our country can eventually lead to that direction. So with that, I would like to say thank you for listening.
Thank you so much, Dr. Annie, for enlightening us. I mean, it's very important that we try to cope with the new technologies in management of type 1 diabetes patients. And congratulations again for securing the BKP grant. Maybe because of time, I probably just allow like one question from the participants. If you do have any question, can just uh, put up or put in the Q&A that may get Dr. Annie to answer. Maybe I can just start. Dr. Annie, I mean, you mentioned the percentage of people using all these new technologies quite small, just about 8%, 10%, that kind of thing. So what do you think the most, what is the most common reason of not using? Is it patient's issue or the doctor's issue?
Yeah, so I think there's multiple issues. Of course, I think the most importantly, the awareness are still not there. Many people still do not aware about the available technology. Okay, we always think it is a money issue, right? But actually, if we really talk to the patient and explain about the usage and let them actually experience it, then they will realize the cost effectiveness of the device. Example, for the CGM study, many of the patients after experience that, the parents are willing to throw in the money because they see the improvement in the patients. Okay, so I think the first important is still awareness. Okay, and of course, second will be the money lah, right? So because it is really costly, just CGM alone, it can cost one is at least 250 to 300 each. That's only lasts for 2 weeks. So for a month, you need about 500, 600 a month. Okay, so definitely it's not cheap, right? So we do hope that there will be more people or government can help the patients.
All right. Thank you so much, Dr. Annie. I think again, very, very clear presentation, and you managed to get through those slides. And I think it's also clear for those who have not had any experience using these new technologies. Thank you so much. I will now pass to the next speaker for the next session. Thank you.